welcome everyone to the Science of Pandemic Tech seminar series. The topic of, so this series is about bringing together science and technology and public health, and basically trying to accelerate that. It's too often too slow that the best science reaches all of the public health and tech people it needs to reach in order to make a difference in the world. And so with this seminar, we're trying to speed things up and have interdisciplinary discussions that will inform digital health interventions, that will inform both public health and tech, with science that we think should be brought to their attention. So if you want to learn more, there are many people here and organizations to follow. Please follow WeHealth, Twitter, Facebook, LinkedIn, your choice. You can follow me. You can follow my co-host from Oxford, Luca Ferretti. You can follow today's speaker, Jennifer Ross from University of Washington. Please follow us to stay up to date with what's going on. Briefly about me, I'm the head of science at WeHealth, as well as having a day job as a professor of evolutionary biology. But math is a common language, and that can be applied to many things, including epidemiology. And there will be some epidemiology today. So basically, today's talk I'm extremely excited about. At the beginning of this pandemic, my university reopened with this program they called Test, Trace, Treat. And it was nice and alliterative, but it felt like a sick joke to me. It's like, no, we're not treating anyone. We're just locking them up and bringing them. Treating means we'll bring you food while you're in the isolation dorm. Like, calling it treat seemed like a sad joke. But today, we can actually treat. We can treat people not just after early diagnosis who are in isolation. Today's talk will be about treating people even who might otherwise be in quarantine, actually giving post-exposure prophylaxis for COVID, which is sort of the ultimate in early treatment. And we have two speakers, one taking that from the clinical evidence and another from the epidemiological. And I think this is a total game changer, and also changes the whole incentive structure on contact tracing, that now being contact tracing gives you access to early diagnosis, early treatment, maybe even pre-diagnostic treatment. So a disclaimer, this is a science talk. We won't be answering medical, personal medical advice. We won't be talking about regulatory matters. We won't be talking about access matters, except in very, not practical ones. We can have general ethical discussions. Please keep your questions to that, and please interpret everything that everyone says in those terms, that this is a scientific discussion. Our first speaker today will be Meagan O'Brien from Regeneron, who's been the lead on critical papers about both early treatment and post-exposure prophylaxis with monoclonal antibodies for COVID-19. And then Jennifer Ross will follow up. She's has a great combination of public health, epidemiological modeling, and clinical experience. We'll talk about sort of the implications of these findings more broadly for the spread. And so with that, I will turn it over to Dr. O'Brien.
Great, thank you so much. My name is Meagan O'Brien. I'm an infectious diseases trained physician, and I work at Regeneron. And I've had the pleasure to work on a number of these programs with RegenCOV, which is the combination of casirivimab and imdevimab antibodies for treatment and prevention of SARS-CoV-2 infection. So let me try to share my screen. Hold on one second. Let me know, is that working for you? Can you see the full screen?
No, we can't see your screen at all. It just worked in practice mode.
Okay. That's the world we live in now, is the technology challenges. Hold on, let me try this.
Inexplicable technology failures. Here we go. We now see your whole there we see your PDF.
Let's try this.
Perfect.
Okay, how's that working?
Yes.
Okay, super. Sorry for that delay. So I'm going to present today data which is publicly available from our clinical trials on COVID-19 prevention and early treatment with subcutaneous administration of the monoclonal antibodies casirivimab and imdevimab. So I work for Regeneron, that's my disclosure. So the Regeneron strategy from the beginning has been to use a combination of two monoclonal antibodies, which are designed to protect against mutational escape of SARS-CoV-2. Shown on the left is a CM map of where the antibodies bind to the binding domain of the SARS-CoV-2 receptor. And so these monoclonal antibodies, which are named casirivimab and imdevimab, they bind distinct non-overlapping epitopes of the SARS-CoV-2 spike protein receptor binding domain, which blocks virus entry into the cell. The combination has been shown to reduce the risk of emergence of treatment-resistant variants, and it's currently authorized in the US for outpatient treatment and for post-exposure prophylaxis under an FDA emergency use authorization, among other countries. So the phase 3 study was designed to assess whether a single subcutaneous dose of the two antibodies, which we're calling RegenCov, could prevent COVID-19 in adults and adolescents living in the same household as a SARS-CoV-2 infected individual. So we used a household contact study design to assess whether RegenCov could prevent SARS-CoV-2 infection in the context of a scenario with high-risk transmission in a household. This is the design that I'm showing you here. It's a phase 3 study using a randomized double-blind placebo-controlled design. So participants were randomized to receive either drug or placebo 1-to-1. And the dose of RegenCov they got was 1,200 milligrams subcutaneous or matching placebo subcutaneous. Eligible participants were adults and adolescents who were asymptomatic household contacts with exposure to a household individual who had a positive SARS-CoV-2 infection. So they were living with an infected person, but they were not themselves known to be infected. They were asymptomatic. The study drug was to be administered within 96 hours of collection of the index case's positive SARS-CoV-2 diagnostic test sample. We did do baseline RT-qPCR test, which was sent to a central lab, and that determined if they were analyzed as part of Part A, which were the uninfected asymptomatic, which was the majority group, or Part B, there was about 10% of household contacts who were asymptomatic, but they were actually PCR positive. So they were very early on in their infection, sort of before they had a clinical presentation. So the Part A analysis, we're going to show you efficacy results for prevention in uninfected participants. And for the Part B analysis, we're going to show you efficacy results for early treatment. So as I said, they were screened. They had to be dosed within 96 hours of the index case or the sick person living in their home, 96 hours from when they had their sample collected, and they received either drug or placebo. And then we followed them for 28 days, looking for symptomatic infection. So as we knew, the transmission cycle of SARS-CoV-2 is 2 to 14 days, but we wanted to understand in the context of this design, if we'd be preventing infection, treating early infection, and even a little bit of information about prevention after that 14-day period, when they might develop symptoms within that transmission period. We further followed them after the 28 days out to 225 days, and that subsequent 7 months was thought to be when the drug might still be on board until it was basically out of the body, and that was mostly a safety follow-up period. For Part A, we were thinking about prevention, and Part B, we were thinking about early treatment, but actually the primary endpoints were very similar. So the primary endpoint for Part A prevention was to understand if we would have differences in the proportion of participants who developed symptomatic infection during the 28-day efficacy assessment period among individuals who were SARS-CoV-2 uninfected at baseline. And then in terms of key secondary endpoints, we were interested to understand the proportion of participants who developed high viral load infection, number of weeks of symptomatic infection, number of weeks of high viral load, any infection, or proportion of patients with any SARS-CoV-2 infection, and of course, safety. For part B, they were asymptomatic, but they were infected at baseline. But we were interested to see if RegenCov could prevent the progression to symptomatic disease. So we were looking at the proportion of participants who were SARS-CoV-2 positive at baseline, who went on to develop symptomatic infection within this efficacy assessment period. For key secondary endpoints, we were looking at number of weeks of symptomatic infection and number of weeks of high viral load infection, as well as safety. In terms of baseline characteristics for part A, you can see that our mean age was in the 40s. This was predominantly enrollment of a white population with 8 to 10% Black or African American, 30 to 40% Hispanic or Latino. You can see the mean BMI. And then in terms of those with increased risk factors for hospitalization, and this was at the time the risk factors that were used by the CDC, and we had about 30% of participants who had increased risk factors for severe COVID if infected. And you can see we had approximately 600 to 700 households per group in this study. This is the main findings of the part A part of the study. So what we're showing here is a cumulative incidence curve, and we're showing that there was the risk for symptomatic infection was reduced by 81.4% with RegenCov versus placebo. And you can see where the curves are actually starting to separate, that there was an effect seen by 1 day after dosing. So this was really immediate protection after dosing in high risk contacts of household infected participants. Here we're showing you in two ways. On the left is really thinking about the data from a population level, and on the right is thinking about the data from a per subject level. So the duration of symptomatic infection was reduced by 93.1% with RegenCov versus placebo. Here you can see on the left, when you combine total weeks of symptomatic infection in each study arm, you're reducing 187.7 weeks of symptomatic infection versus 12.9. And then on the right-hand side, you're looking at duration of infection per symptomatic participant. So in placebo, the mean number of weeks of symptomatic infection was 3.2, and in RegenCov it was 1.2. So if you entered the study and you were uninfected and you did go on to get infection, your infection duration was 2 weeks shorter. The duration of infection, whether symptomatic or asymptomatic, was reduced by 82.3% with RegenCov versus placebo. Again, looking more at the population level per treatment arm, we're looking at 231 combined total weeks in placebo versus 41 in drug. And then at a per subject level, the duration of any infection went from 2.2 weeks down to 1.1 week. Again, for part A, so the duration of high viral load infection, which we used a cutoff of 10 to the 4 copies per ml, was reduced by 89.6% with RegenCov versus placebo. So you can see here again at the population level, 136 weeks of high viral load infection versus 14 weeks on drug. And then per subject, 1.3 weeks with placebo versus 0.4 with RegenCov. So a big reduction in high viral load infections. In terms of the early treatment group, part B, so again, these were the participants who were asymptomatic and not known to be infected, but actually had early infection in the study. This group similarly, mean age in the 40s, predominantly white and Latino. You can see the average BMI here. And similarly, about 30% had risk factors for development of severe COVID if infected. About 10% were over 65, and then 10 to 15% had a very high BMI, 5 to 10% with diabetes. So in part B, what we found was that REGEN-COV reduced the risk of progressing from asymptomatic to symptomatic infection by 32% versus placebo. Here you see the lines start to split by around day 4. And what we think is happening here is that in the first few days after dosing, this is where participants are already on the path to developing symptoms. So within the first couple of days, the disease progression may not be modifiable. But after day 4, you see a nice splitting of the lines with the reduction in the development of symptomatic infection by 31.5%. So REGEN-COV reduced the duration of symptomatic infection by 45% in symptomatic participants versus placebo. So again, looking at the population level here, so the total weeks of symptomatic infection for all participants in each arm, 170 versus 89.6. And then in terms of per participant, the mean weeks went from 1.6 down to 0.9. Looking here, REGEN-COV reduced the duration of high viral load detection by 40% with placebo. So looking at the mean number of weeks of high viral load, it went from 0.8 down to 0.5. In terms of safety, REGEN-COV was well tolerated. Treatment emergent adverse events occurred in greater than or equal to 2% of participants in the overall study period. And there were more COVID-19 related adverse events in the placebo group, which is in accordance with the data where we're showing that there's more COVID-19 occurring in placebo in general. So in terms of the most common AEs in placebo, COVID-19 occurred in 8.6% versus 1.1% in drug. Asymptomatic COVID-19, 8.3% in placebo versus 4.1% in REGEN-COV. And then headache and injection site reactions also occurred. Injection site reactions were observed in 1.5% in placebo and 4.2% in REGEN-COV. And in REGEN-COV, all of the injection site reactions that were observed were grade 1 and 2 and were treated, they were either self-resolved or treated with over-the-counter medications, so mild to moderate in severity. In terms of more safety data, you can see here that the number of treatment emergent adverse events was 109 in placebo versus 67 in REGEN-COV. This is for part B. And you can see in terms of non-COVID treatment emergent AEs, there were 42 in placebo and 26 in REGEN-COV. Any of the higher grade treatment emergent AEs, there were 5 in placebo, 1 in REGEN-COV, and then all of the serious treatment AEs occurred in the placebo group. There were no deaths in this part B of the study. So in conclusion, what we found was that administration of 1,200 milligrams subcutaneous dose of REGEN-COV antibody cocktail reduced the risk of developing COVID-19, reduced the duration of symptomatic disease, decreased the duration of detectable virus, and was generally well tolerated. Just to acknowledge the participants, their families, the investigational site members involved in the study, the COVID-19 phase 3 prevention trial team, medical writing support, and this study was supported by Regeneron and Hoffman-La Roche. And we conducted the trial with the National Institute of Allergy and Infectious Diseases and the National Institutes of Health. These are other notifications about REGEN-COV. Again, it's authorized for use currently in the US and in other countries. And this is more information on statistical analyses for those that are interested. I think that's the end of my talk. I'll turn it back to you, Joanna.
Okay, thank you very much for those extremely positive results. So I'll now turn over to Jennifer Ross to say what all of these beautiful clinical data mean for the epidemiology.
Great, thank you. It's great to be with you all today. Are you seeing my slides okay?
Yes, looks good.
Great. So I'm Jennifer Ross. I'm an infectious disease physician scientist at the University of Washington. I'm based at the International Clinical Research Center, and I've worked with colleagues here at the University of Washington to investigate the health impact and cost of COVID-19 post-exposure prophylaxis with monoclonal antibodies, and we're specifically looking at post-exposure prophylaxis within households. My disclosures. So in our time together, I'll go through some background for household-based prevention, the research question that we developed, how we approach this problem using a decision analysis model, what we found, and then go through some assumptions involved in our work and how we're interpreting the findings. So to begin with background, and I'm going to just arrange a little bit here. We know that household contacts are at elevated risk for SARS-CoV-2 transmission, similar to many other pathogens that are transmitted within households. This is a systematic review and meta-analysis published actually pre-Delta, but looking at the secondary attack rate, so that the proportion of close contacts who would be infected from someone with SARS-CoV-2, and finding a 21.1% secondary attack rate among people within the household, and comparing this to other settings where people may have exposure, social gatherings with small groups of family and friends, travel, workplace, or healthcare, and finding this high rate of transmission within households. We also know that the vaccination rate within the US has not achieved a high enough level to allow for herd immunity, and that there's household clustering of vaccination status. So a study from the Kaiser Family Foundation, a survey from the Kaiser Family Foundation, found that 69% of respondents who were unvaccinated also identified that everyone within their household was also unvaccinated, versus 77% of participants who said that they were vaccinated and indicated that everyone within their household was vaccinated as well. So there's a strong household-based clustering of vaccination status within participants in the US. And this was a survey done in June of 2021. We also have examples from other settings where household-based post-exposure prophylaxis is used successfully. Prior to COVID, and I would say still during COVID, most of my work is in tuberculosis, where we used household-based TB preventive therapy because it's effective in preventing people who have been living with someone with active tuberculosis from developing active TB themselves. And we also find that household-based post-exposure prophylaxis is a way to encounter people in a feasible way who have been exposed within the recent past, which is an important timing consideration for TB preventive therapy. I'm having some delay in advancing my slides, but there we go. Some additional background here specific to COVID-19 monoclonal antibody post-exposure prophylaxis. So we had an early study out showing that the monoclonal antibody bamlanivimab reduced symptomatic COVID-19 by more than 40% among nursing home residents who received it within 7 days of exposure. And then, as we've just heard from Dr. O'Brien, the combination of casirivimab and indevimab reduced symptomatic SARS-CoV-2 infection by about 81% among unvaccinated SARS-CoV-2 negative household contacts. So this is corresponding to the part A of what we just heard. We've also seen that the FDA has issued an emergency use authorization for the Regeneron combination for use as post-exposure prophylaxis. So this led us to develop the following research question. What are the health impacts and costs at the population level of providing monoclonal antibody prophylaxis to unvaccinated household members of people with COVID-19 in the US population? And in terms of defining health impacts, we're looking specifically at SARS-CoV-2 symptomatic infections, hospitalizations, and deaths averted. And we're also looking at costs from the health system perspective. So the costs of the treatment itself, the administration of the treatment, and then the hospitalization costs averted. And the findings that I'll be talking about today are covered in a preprint that we recently posted. And I've included the link here if folks are interested to learn more about this analysis. So in talking about our approach, I'll begin with a walkthrough of our conceptual model here. So we're interested specifically in how COVID-19 burden falls within the age, race, and gender groups within the US, and then how those groups are assorted within households in the US. So our model brings together COVID-19 case data reported to the CDC for a representative month. In this case, we're modeling May 2021, where we're calculating then what are the frequencies of COVID-19 cases among people based on their age, gender, race, ethnicity, and also bringing that together with census microdata, so the individual line level data from the American Community Survey, to understand how individuals are assorted within different households. Also, we have the vaccination status that we're including from the Kaiser Family Foundation survey, that survey I mentioned at the beginning, showing that there's household-based clustering of vaccination status within the US. So we're bringing those elements together into a model that uses a Monte Carlo approach and quantifies uncertainty with non-parametric bootstrap resampling. So here in the middle, as I'm showing the households here, I'm showing that we've calculated some probability that based on the COVID-19 case data and also how individuals are assorted within households, some probability that this household here identified in orange contains somebody with COVID-19. And then what we can calculate what the probability is that their household members are of a given age, race, and gender. Then we have a step where we're modeling one wave of intra-household transmission of SARS-CoV-2 infection. And we used the data from the placebo group of the casirivimab and imdevimab post-exposure prophylaxis study to calculate what's the probability of intra-household transmission. Based on those that transmission within the household, then we can estimate what's the likelihood of an individual who has symptomatic SARS-CoV-2 infection progressing in their infection to need hospitalization based on their age and gender. And then at that point, that's where they also incur additional healthcare costs related to the hospitalization. Our simulation also includes post-exposure prophylaxis. So that's the comparison scenario, is that we can provide or include model the provision of post-exposure prophylaxis to individuals within the household based on their age. This is getting more into the second half of our model there, where we're looking at the decision analysis. So showing that with the single choice node here, the blue square showing post-exposure prophylaxis for an individual household contact based on some chance nodes here shown in green for secondary infection, hospitalization, and death. So with the ultimate outcomes here being death or recovery as shown by the orange triangles. These are the key parameters in our model. As I mentioned, we're including COVID-19 case data from CDC. In this case, they're from May 2021, so a time when cases were relatively high, but declining, and not nearly as high as we've seen over the last several months. So most of this scenario happens to be pre-Delta wave in the US. We're including the household composition from the American Community Survey, vaccination clustering from the Kaiser Family Foundation, as I mentioned, rates of transmission from the trial, and then efficacy data from the Regeneron trial as well. We included an estimate of the medication cost here that was based on the government purchase price for bamlanivimab. I think that's a parameter that likely will be updated in our next estimation round based on experience with RegenCov. And then we went to the literature for estimates of what the cost of clinic-based subcutaneous administration of the antibody would be, as well as estimates of the average cost of a COVID-19 hospitalization, which from our review were more than $70,000. So this is kind of the bottom line up front here in terms of our findings. From our model, we found that in a month of similar intensity to May 2021, for a program that was implemented across the US, a monoclonal antibody post-exposure prophylaxis program that reached 50% of exposed unvaccinated household members who were age 50 or older would prevent about 1,800 symptomatic infections, more than 500 hospitalizations, and about 83 deaths. And assuming the intervention cost that we did, so the cost of the study medication as well as the cost of administering it, it would be modestly cost savings, or I think in our interpretation about cost neutral in terms of the cost of implementing the program and also the hospitalizations that were averted. So we'll dig into this a little bit more in terms of some of our scenario analysis and how we got to the specific scenario of reaching 50% of household members and the age threshold here of 50 or higher. So in our scenarios, we compared all of the intervention scenarios to a baseline scenario where there was no post-exposure prophylaxis, where we estimated that there would be more than 250,000 unvaccinated household contacts in that month. And that if there were no post-exposure prophylaxis program, there would be about 2,000 hospitalizations and more than 200 deaths. And then we looked at comparison scenarios based on age threshold for treatment. And the reason we looked at age is because there's such a strong relationship between age and risk for severe SARS-CoV-2 infection, including hospitalization and mortality. So in our next line, we have our most restrictive scenario where we offer post-exposure prophylaxis to household contacts who are at least 80 years old. That's our smallest group of contacts, where we have just over 3,000 unvaccinated household contacts. So this also incorporates the age gradient for vaccination in the US, at least it was present in our data sources at the time through about June of 2021. And found that this program would be associated with about 203 deaths related to household exposure. So the averted number of deaths here would be 227 minus 203, so somewhere in the 20s there. The middle scenario was targeting folks who are at least 50 years or older for post-exposure prophylaxis. We found a larger group of contacts, more than 50,000 contacts, including them corresponding to about 28,000 who would be treated and resulting in 143 deaths. And then our most kind of expansive scenario, where we looked at everybody who was 20 years or older, would identify a much larger group of contacts and result in about 134. So as folks are looking at these numbers, you can see that there's kind of several nonlinear relationships here in terms of the hospitalizations and the deaths from household exposure, and that's related to the differences in risk for severe SARS-CoV-2 infection or COVID-19 based on age. As I mentioned, these findings correspond to 1 month of program implementation for population transmission parameters that are similar to May of 2021. And then we looked at incremental cost effectiveness as well. And so on this slide, on this figure, the different colors correspond to different age-based thresholds for administration of SARS-CoV-2 post-exposure prophylaxis. So the blue circles here correspond to the kind of the most restrictive scenario, where the treatment is only offered to people who are age 80 plus, and then on down to the most expansive scenario here, where in pink, where we simulate treatment for 50% of individuals who of any age, so 0 plus. And in this case, each circle corresponds to one iteration of our bootstrapping analysis. So there are 100 circles in every color group. And we see here that as we're looking kind of in the middle groups, I think the parts of this figure that are most interesting to our team are the 60 plus, the 50 plus, and 40 plus groups, where we start to see the greater number of deaths averted, shown with on the x-axis here, but also with the relatively low incremental costs. And in our analysis, at least with this sets of parameters and assumptions, we found that the maximum reduction in incremental cost was in a program that was targeted to individuals who are 50 years or older. So in terms of the assumptions involved in our model and how we're interpreting it, we think that this work shows that despite some conservative estimates, that the monoclonal antibody prophylaxis would avert sufficient morbidity and mortality to be an efficient use of resources. And in terms of the conservative estimates, a couple of things that I'll point out here about the way we approach this. We had a relatively low secondary attack rate that we estimated using the data from the study. So we incorporated a secondary attack rate of 7.8%. As we've seen in terms of the literature, that's relatively low compared to what's been seen in several other settings. And it also corresponds to a time when the study took place was before the Delta variant. So in fact, the intra-household transmission may be even higher in Delta settings. Also, our model includes the impact of one wave of transmission, but we know that with infectious diseases, when someone's infected, it's not just that first wave, but then that person can go on to expose other individuals potentially outside the household as well. And so we're not including all of those ripple effects in this estimation. And so as we're continuing this work, we're anticipating that increased infectiousness from the Delta variant could modify results in our next estimation round. Another key part of this work is that we have assumed that unvaccinated individuals in this case are fully susceptible. So we have not incorporated the partial immunity or the immunity that folks may have from prior infection. And that's something that, as we've had longer and longer as the pandemic goes on, more and more folks may have immunity from prior infection as well, and that may modify our results in our next estimation round as well. So I'd like to acknowledge our team here at the University of Washington that carried out this work, and link to the preprint again for folks who are interested in learning more. I'm happy to take questions either during this session or by email. Thanks for your attention.
So thank you both very much. And I'm now going to cheat and use the moderator's prerogative to ask the first question because I can't help myself. So both Luca Ferretti and I have been longtime proponents of daily rapid antigen testing following exposure, including transit exposures, non-household exposures, work exposures and so on. So I guess this is a question for Dr. Ross that I realize, that's not what your study was on, but is there a way of, say, extrapolating the Part B results to the benefits, to calculate the benefits of a daily testing followed by treatment upon first rapid antigen positive test so that we could catch a much wider set and at that point also the onward transmission becomes more important too, because that non-household transmission, of course, leads to household transmissions, but doesn't have to if you catch it early enough and so on. But even leaving aside that section, do you think you could get at a broadening at the cost of slightly later treatment of treating after the first rapid antigen test?
Yeah, I think that's a great point. There are lots of different ways to look at this, and that population that you're talking about, if I'm understanding correctly, are folks who already now have a documented SARS-CoV-2 infection that's early stage. And so you could use the approach that we did to then predict what the risk for hospitalization or additional bad outcomes would be based on age and gender. And look at that fairly closely. And that group actually would be sort of even at higher risk than the group that we modeled, because they already have a documented infection. I think going on to the ripple effects is really interesting, and there are lots of groups that are putting together dynamic models of SARS-CoV-2 transmission, and that's the way. I mean, that's very interesting to do, also challenging in terms of how quickly things are changing right now.
Okay, so for the next question, Debo Awisaka Alumo, I think Queenie will let you speak. She's got the control of that. You're still muted, Debo.
Hello, can you hear me?
Yes, we can hear you.
Okay, this is for Dr. Brian. Your slides 7 and 11, the total percentages of participants, white, Black, and Latino, was more than 100%. Please, can you clarify that? Secondly, the enrolled Black population was lower than the US population. Is there anything beyond convenient sampling?
Thanks for your question. So I'm looking at slide 7. So basically the way we designed the study was that we enrolled households in the US and 2 countries outside of the US, Romania and Moldova. And we were really going for hotspots in the US. And so we were enrolling a lot in the Southeast and the Southwest. And those areas were enriched for Latino populations. So I think it was just really sort of a matter of where the outbreak was at that time in terms of the populations we were enrolling. We were working with NIAID, NIH, and we, in the early days, were really thinking hard how to enroll a more diverse population. So we had different strategies to try to enrich for African American and Black participants. So those numbers improved over time. But essentially, it was about 10% over the whole study was Black or African American, and about 35 to 40% of the whole study was Latino. And I think when you break it down into the group A and the group B, the group B numbers were just smaller. It was about 10% of the study. So then the numbers might have shifted a little bit, but it might not have come through with the presentation because I separated it into group A and group B, but that's essentially the way we're enrolling participants. Does that answer your question?
Yeah, thank you. I was also looking at the total percentage of the participants. If you add all of them together, the Black, the white, and the Hispanic, it's more than 100%. So I was just trying to see whether you have this kind of non-Hispanic,
Oh, I see. I see.
Yeah.
Yeah, the way the data was entered was race is different from ethnicity. And so participants themselves self-identified by race and by ethnicity. So they would, tell the investigational site how they identified, with these different categories of race, and then also how they identified with these different categories of ethnicity. And so it would likely never add up to 100% because Latino is in a separate bucket. That would be sort of the ethnicity bucket. So they could be both white and Latino, both Black and Latino. There was also, of course, participants who didn't want to identify as any race or any ethnicity, or people that identified as more than one. So I think that's probably why it's not adding up to 100%.
Thank you.
Sure.
Okay, the next question is from Howard Haft.
Yeah, hi, thank you very much for this presentation. It's exciting, both in the post-exposure prophylaxis and in the treatment aspects. But we've been looking at the numbers of people who still die from COVID, and a significant percentage of those apparently have not had either post-exposure prophylaxis or treatment. I was wondering if there's any kind of data nationally or state by state that looks at that particular aspect. How many people died from COVID? How many have had an opportunity or have not had an opportunity to be treated? And kind of as a corollary to that, is there sufficient monoclonal antibody supply if we were to treat everyone who is eligible?
In terms of data for who's been offered treatment and who's been offered prophylaxis out of who is available to receive such treatment, I'm not aware of those numbers, or if others are trying to figure that out. But in terms of drug availability in the US, we're responsible for the drug alongside with BARDA, and there is drug to date for what is, there's plenty of drug available. Outside of the US, our partners Roche have been working to work with different countries for emergency use authorization and to get drug to them. So it's really on a country by country basis. But I don't know if others know the answer to the first question. I think that's a really interesting question. How do you ask that question, and how do you get that data?
I saw a figure that it was 30% in the US of those eligible, but that's probably a month or two out of date by now. And that 30% eligible were getting the monoclonal antibodies.
Interesting. Yeah, I mean, if it's interesting because the emergency use authorization and the CDC criteria have changed for who is high risk. Right. So back when we performed the study, like what I showed you, about 30% would have been called high risk. And actually they shifted the BMI lower to high risk, being, from obese to overweight. And then if you reanalyze the data, we did this in our New England Journal paper, our, general population, actually it turned out to be 70% high risk, just mostly because of that BMI shift. In terms of who would be thought to be maybe at high risk to develop severe COVID if infected. So I thought that was interesting as well. I don't know if the 30% and 70% are related or are different to the numbers, Joanna, you had thought about.
I think that's coincidence.
Yeah, thank you. That's helpful. Appreciate that.
Okay, the next question is from Carmen Williams, but I'm just going to semi-moderate it, although we'll still let Carmen speak. So just to bring everyone up who hasn't had a chance to look at the news today, that Colin Powell has died at the age of 84 with COVID complications. I read the news enough to see that he also is reported to have had multiple myeloma, which means we can assume most likely that he is immunocompromised at the time as well. The reports also say that he is fully vaccinated. And I saw a report that referred to 2 doses and then said it was unclear whether he'd got a booster. Just reporting what I saw in the media this morning, in case our speakers get put on the spot without having had a chance to read the news first. And then also, obviously, nobody is commenting here or answering about anything they might know about Colin Powell's specific medical situation or his, but I mean, generally, if we take somebody like Colin Powell, who is fully vaccinated, what do we think is going on? Right? I mean, again, it's a question, I guess, related to the last one of what is, how are people, obviously this is a person who could benefit because he turned out to die. We don't know whether he did get treated or not. Can you comment about people who would fit into the broad category of people like Powell? And I think obviously that's a question for Dr. O'Brien.
I think people like Colin Powell would fit under the emergency use authorization for sure, based on many of those factors, comorbidities and age, for outpatient treatment, and that's really what the EUA is authorized for. There's data from recovery, and also we have some data for different groups of hospitalized patients who may achieve benefit from the drug, but none of that is authorized yet. So hospitalized patients right now are not under the EUA. But I think for sure in the outpatient setting and for prevention, if he was exposed to somebody that was infected for post-exposure prophylaxis, he based on our data would have benefit. And then the same thing for early treatment, in the outpatient setting. So we obviously don't know what his medical care was though.
Yes, it is a reminder that some people, especially older and with comorbidities, remain vulnerable after full vaccination.
Yeah, there's a growing body of research in, hematological malignancies and transplant on immunosuppressant therapy, different immunodeficiencies where they don't show immune responses after vaccination. They're mostly looking at antibody responses, and there's, different antibody tests that you can perform. But I think there's a growing body of evidence that there's definitely certain populations that are not going to have a strong immunological response to vaccines. And, that's likely a vulnerable population in terms of.
And I know my colleague at the University of Arizona, Deepta Bhattacharya, just had a paper out in Nature Medicine that was very promising with respect to third dose booster shots in this particular population. So, it seems that by just boosting more, one can actually get, you can reach this compromised population, but it takes more work on the vaccination front.
Yeah, that's a great point. I think the earlier studies were after a single dose and then after 2 doses, but I think that's a great point, learning more about what that third dose can do in this population. And then of course, vaccinating everybody regardless, with all of the boosters that are recommended is the key thing to do for sure.
Okay, I think we just have another quick question from Howard Haft that we won't bring him back for, which is, can you answer any questions about slide sharing? And I'll just say that the video itself, which obviously includes the slides, but less conveniently will be on YouTube, which you can reach via WeHealth's website. If any of the either of the speakers wish to share slides, we can distribute them if they wish, for example, as they wish. Example, just to attendees or registrants or whatever. And any links to anything will be shared on Twitter. And in fact, as soon as the YouTube goes up, we'll put that up on Twitter, so you can follow us on Twitter in order to know when the YouTube is live, if you want to share it with others who you think really should have been there. Oh, we actually ran out of questions 5 minutes before Dr. O'Brien's hard stop, but I can see that Luca is opening his mouth.
I have a question both for Meagan and for Jennifer. What do you think about the timing? So how important is to get this treatment early? Because of course there are different options depending if, for example, one uses contact tracing mostly to get these treatments as early as possible, or if one, for example, confirms them with daily testing and acts only upon positivity. So there are trade-offs, I think, in that sense. So my question was, what do you think about the timing itself? How important is it?
Maybe I'll let Jennifer speak first since I have taken most of the questions.
Sure. I think maybe I'll come at it from the feasibility angle and defer the kind of efficacy to you, Megan, but I think that's one of the strengths of using a household-based approach is the feasibility of identifying contacts kind of in that early window when our studies have shown that the therapies or the prevention is most effective. But you know, in the case of the work that you and others are doing for identifying other contacts in that early window too, then I think that would really strengthen the utility of these treatments.
Yeah, I totally agree. I mean, the more testing that's available, the better, so we can identify folks in the earliest windows. It's, you know, similar to other antiviral approaches. Early treatment is best, you know, prevention is even better. So I totally agree. Whatever we can do to have more access to more accurate, easier to do testing, the better.
Yeah, and I think for both Luca and I, part of what we see about automated digital solutions to contact notification is to make testing salient, that most people are not going to test weekly or bi-weekly or so on for their whole lives, but maybe we can get them to test daily for several days following exposure at the times they're most likely to test positive.
Yeah, I agree that for household contacts, this is probably a secondary issue, and this instead is more important maybe for other kind of contacts where also the second attack rate is lower. So you should use more monoclonal antibodies on a wider range of the population, and it would be probably more complicated without testing. That's a good point.
Yeah, we'd love to one day see the data on just how tested, you know, just exactly how does efficacy depend on date of treatment. Like, we know that earlier is better, but how steep is that relationship would be, you know, I mean, one can guess a priori that every day earlier is better, but like by how much? Is there any way of analyzing that data and perhaps getting a feeling on how long it might have been, like based on symptom onset date in the index case in the study versus the date of administration to the contact? Is there any way of sort of getting a handle on that exact timing issue?
Yeah, that's a very important open question to learn more about. You know, what are the variables related to transmission? Is it the viral load of the index case? Is it the behaviors in the house? Is it the time of days of symptomatic infection? You know, we and others have projects working in this area, but I think those are key questions. And I don't think we know all the answers for sure.
Okay, on that note, we will close out here. Thank you all for coming. Thank you for our two speakers. And so often we have, you know, negative news to present in this. It's so wonderful to have a seminar that's all about good news. So that makes us all really happy. Thank you so much.
Yeah,
Thank you
thanks so
very
much
much.
for the opportunity. Thanks so much.